Good evening, everyone. We are very excited to welcome you to our very first Essity South Africa webinar, which is the first of more to come in 2021. My name is Jason Reynolds, and I am the Senior Brand Manager in charge of wound care at Essity, and I will be your host for this evening. Tonight, we focus on the very important topic of debridement, and we will also introduce you to our new amazing mechanical debridement pad, Cutimed DebriClean. As this is our first webinar, I hope that everything runs smoothly, but as always, gremlins can attack it, in which case we will try to resolve this as quickly as possible, and we ask that you bear with us if this happens. So I think we can all agree it's been a really crazy roller coaster year with much change and adaptation needed for everyone. And as this year draws to a close, I see many people dealing with the aftermath of all of this, and so we've endeavored to put together what we hope will be a fun, educational and entertaining event to end your year of webinars off on a very high note. The concept behind this event was to shift a little from the standard format of sequential presentations and rather to focus on having our expert panel present and discuss the topic, and then very importantly, to make this as interactive as possible and to spend as much time as possible fielding questions from you, the audience, to really get to the bottom of the issues that you are grappling with when it comes to debridement and wound bed preparation. So this is basically the program then. I will take a quick opportunity to introduce you to our product, our new product, Cutimed DebriClean, and then hand over to our expert panel who will present and debate for around 45 minutes. And then we will open for Q&A from the audience till about 8 p.m, upon which I will end the official session. But for those who wish to stay on for more Q&A, we will continue with this right here in the same venue until 8:30 p.m. So some quick house rules. Should you wish to post questions to the speakers for discussion, please do so in the Q&A section. And feel free to also post comments in the chat section for general communication with online delegates. You can find these functions on the right of your screen. For your CPD points, please go to the Event Activity tab. Make sure that you download and read the pre-reading document and then answer the multiple choice quiz, for which you will need to achieve a pass mark of 70% for 2 CPD points. Please note that there are no CPD points for the webinar itself, only those linked to the pre-reading document. Our product quizzes are also in the event activity section, and before you answer them, I encourage you to review our product section, which includes product brochures and videos, if you haven't already done this, and these will help you answer the questions. The top scorers stand a chance to win some lovely prizes for their practice, so go on and go for it, guys. Should you wish to have one-on-one meetings with your Essity representative, you can set a meeting with them through the app by entering the attendees section on the site. The list of the reps and sales managers is in the speaker and rep section below the speakers. Just click on the rep to see which territory they cover. And then the site will be live till the end of the month, so that's 30 November. So please do play around with the site's various features till then. However, with regards to the one-on-one meetings with the reps, this functionality will close on Friday evening, this Friday, but of course our reps will still be available through normal communication channels. In the product section, you will also see a list of distributors listed there under the products. We have arranged some great launch specials for you through these distributors, and we encourage you to take advantage of these excellent deals while they're still available. Everyone who opts to receive a Cutimed DebriClean sample pack during the registration process, you have an option there. You will be receiving one by courier after the event. If you do not receive one and you would like one, please just get in contact with our representatives and they will get on it right away for you. So now, onto the topic for tonight. Debridement, as we know it or as we think about it, should not just simply be debridement on its own. Current best practice focuses on wound hygiene as a whole and involves biofilm-based wound care practices. And it's here that we need to make a fundamental shift in thinking. And we need to think of wound hygiene more like other hygiene practices we are used to, much like the need to brush, floss, and rinse your teeth regularly. So too, it needs to be with wound care. In reality, though, research shows that the correct or appropriate wound hygiene and debridement is not being practiced, which is detrimental to wound healing. And as such, this is a very important topic that we should all be paying attention to and addressing this as this is where wound healing really starts. So I'll take a quick moment now to showcase our newly available mechanical debridement pad, Cutimed DebriClean, before I introduce tonight's speakers.
The Cutimed DebriClean pad has been specially designed to support you in the debridement process and lead to more effective wound closure. Its hand loop provides an easy, comfortable and accurate use. Its hard blister pack can be used for moistening and disposal. Dependent on your local guidelines, all commonly used rinsing solutions can be used, based on PHMB, sodium hypochlorite or hypochlorous acids, octenadine, 0.9% medical saline solution, water and Ringer's solution. Thorough wound cleansing is the foundation for successful wound healing. Cutimed DebriClean efficiently sets the stage for the wound healing process with its unique and innovative design. Thanks to its combination of gentle looped monofilament fibers and abrasive fibers, bacteria is absorbed and firm slough removed, making Cutimed DebriClean suitable for any wound cleansing challenge. In vitro testing, Cutimed DebriClean excelled in bacteria binding when compared to other products. Cutimed DebriClean achieves more than 99% biofilm removal with just 4 wipes. Cutimed DebriClean has demonstrated its strong cleansing efficiency. Choose Cutimed DebriClean for a fast and effective wound cleansing.
So now I'll introduce our expert panel who will lead us on our journey tonight. First is Dr. Vivien Jandera, a prominent plastic and reconstructive surgeon practicing in Pretoria. Dr. Jandera is currently the past president of the Association of Plastic and Reconstructive Surgeons of South Africa, and with 23 years experience as a specialist, her career has involved both state and university senior appointments, as well as private practice where she currently operates. Next, we have Sister Helen Loudon, who is a highly experienced and skilled independent infection control and prevention practitioner and clinical risk management nurse specialist. Helen's special interests and areas of expertise include drug-resistant pathogens in high-risk patient populations, strategies for the prevention of healthcare-associated infections, antimicrobial stewardship, and advanced wound management. Based out of KwaZulu-Natal, she also authors our monthly Microbe of the Month and quarterly The Link newsletters. And if you aren't receiving these already and would like to, please do get in touch with us. Then we have Sister Liezl. She is a highly qualified and experienced clinical nurse specialist in wound management and extremely passionate about education. She runs her own educational and training academy called Eloquent Learning Health out of Pretoria, as well as running a thriving clinical practice, Eloquent Health and Wellness. She is the founding member and past president of the Wound Healing Association of South Africa and remains very active in many facets of wound care, not only in South Africa, but abroad too. And then last but not least, we have the always radiant Tshidi Mbonani, who is a senior podiatrist at Hani Baragwanath Hospital in Johannesburg, where her dedication to limb preservation and advanced wound care has seen her heading the Wound Care Committee, as well as serving on the Wound Care Advisory Panel. For those who don't know, the Hani Baragwanath Hospital is the 3rd largest hospital in the world, occupying around 173 acres with approximately 3,200 beds and about 6,760 staff members. So as a highly skilled podiatrist, Tshidi really is a true expert in the topic of debridement. My introduction, of course, does not do them justice, so please take the time to take a look at their profile information in the speaker section to learn more about them. And now, without further ado, I would like to hand over to Sister Helen Loudon, who will kick off the session for the experts. Sister Loudon, over to you.
Good evening, everyone. On behalf of my colleagues, Vivien, Tshidi, and Liezl, thank you so much for joining us tonight, especially after a long day's work. We really do appreciate it. Thank you too for the introduction, Jason, and to Essity for the invitation to present on such an important topic in advanced wound management. We do hope that you will gain some useful information which will benefit your more challenging patients. So to start off, As we've said, we're going to be looking at the how, what, and why of wound debridement. The intention is to be very clinical about our discussion this afternoon and to give you hints and tips that hopefully will benefit your practice. Go to the next slide. The areas that we're going to cover this evening, firstly, we need to start where it all begins, and that is, what are biofilms? Then I'm going to explain why the combination of slough is such a physical barrier to wound healing, and the combination of biofilm and slough in a wound is a huge clinical concern and the reasons for this. Then I'm going to hand over to my colleagues, and we're going to discuss why do we debride, how should we debride, when should we debride, and importantly, when is debridement contraindicated? And then finally, we're going to have some case studies that we're going to open up to you of more challenging wounds. Next slide. Firstly, let's start with what are biofilms. A biofilm is a structured polymicrobial community of microbes. That is, it's made up of many, many species of bacteria and fungi, and they are all encased in a very complex EPS, slime or glue-like substance, which irreversibly adheres them to a surface, in this case, the wound bed. This slime protects microbes from the patient's immune response, and they are extremely tolerant to antibiotics and antiseptics. Biofilms form within hours, and importantly, they reach maturity within 48 to 72 hours. The biofilm life cycle is literally that. It's an extremely dynamic process, and many of you will be familiar with this illustration. On the left-hand side, you will see that planktonic or free-floating bacteria and fungal spores, they land in the wound from the environment, from the patient's hands, from healthcare workers. And within a matter of hours, they have attached. Within 3 to 4 hours, they start producing the slime or biofilm. And within 24 hours, the biofilm is significantly mature enough and large enough where it starts fragmenting and breaking up and then spreading to other parts of the wound and elsewhere in the environment. So you can see biofilm is not only a problem for the wound environment, it's also a problem for infection control. You cannot see biofilms. They are microscopic structures. They're only visible on electron microscopy. If you look on the left-hand side, at first glance, this wound might seem perfectly okay. If you look closely, you can see a shiny fibrin layer. That is hiding a whole lot of evil, I can tell you. And on the right-hand side, those highlighted bright red areas of tissue, that is microbial biofilm. Those are colonies of microbes that have been tagged with a fluorescent dye in the laboratory. And this shows you that biofilm is at least 5 millimeters below the wound surface. Next slide. So why is the combination of slough in a wound with biofilm such a clinical concern? If you look at the slide, I'm going to be going round in an anti-clockwise direction. In a nutshell, this is where the party is happening, quite literally, and it's very important that we understand all the activities that are going on inside biofilm. On the left-hand side of the screen, underneath the image of that venous leg ulcer, you'll see a pink cyclical diagram illustrating Cullen's cycle of delayed wound healing. So called because chronic and hard-to-heal wounds typically become trapped in a vicious cycle of low-grade inflammation. And this is caused by the ongoing production of damaging proteases and cytokines, which are produced both by leukocytes and bacteria. It's also important to understand that the bacterial flora of chronic wounds comprises mainly gram-negative fecal species. And some of the more commonly ones that you will recognize are Proteus mirabilis, Pseudomonas aeruginosa, or E. coli, just to name a few. Now, these fecal species, they alter the biochemistry of the chronic wound, and they do this to maintain an alkaline pH. Now, the healthy pH of a healing, progressing wound should be around 6.5 to 7 or neutral, but fecal species predominate in chronic wounds, and you will find a pH of at least 8 or 9. This favors low-grade inflammation. It increases exudate production, and you've often wondered why this happens when you have slough, and of course, delayed wound healing. Meanwhile, biofilm provides the perfect medium for communication between these microbial communities. And the term we use is called quorum sensing. This is a critically important mechanism whereby bacteria regulate their numbers and they ramp up virulence tactics, such as the secretion of exotoxins and even more biofilm. Finally, at deeper levels in the biofilm, and we're looking on the right-hand side of your slide now, microorganisms slow their metabolic rate to an almost dormant level, whereby many of them become anaerobic. In other words, they don't require oxygen to survive. And many of your gram-positive species, such as Staph aureus, it may surprise you to know, can become anaerobic. And consequently, they have very little nutritional requirements. This is especially significant with regards to developing tolerance to antimicrobial substances, that is antiseptics, silver, and antibiotics, and the development of resistance. Therefore, if a microorganism is not metabolically active, it won't take in antimicrobial substances from the external wound environment. And finally, in this slide, on the right-hand side, can you see those two orange microbes? The one on the right has a lot of pili. Do you see the little black spikes? That's what they attach to the wound bed. These are two E. coli bacteria, and they're connecting via a tube structure, and this is called a sex pilus. This is literally unsafe sex between bacteria in the biofilm. And this is how bacteria exchange multi-drug resistant genetic material via plasmids. And for example, this is for methicillin resistance, which you will know as MRSA, or carbapenem resistance, which we also term CRE. So that's just a little glimpse into the party that's going on in the biofilm in your chronic wound. Wound culture. Time is limited, but the most important thing I want to say to you here is please do not swab chronic wounds unnecessarily. Superficial swab culture is actually a very unreliable tool in order to make a diagnosis of wound infection, or especially to guide antibiotic therapy. If you are going to swab a wound, it's very important that the wound should be well debrided first and then thoroughly cleansed with sterile water or saline. Please do not interpret a laboratory culture result in isolation. If you get a no growth, you've actually taken a bum swab. You should always culture something. But the diagnosis of a wound infection should always be made in the context of wound assessment, the patient's overall condition, and of course, any underlying risk factors. If you are suspecting involvement of a multi-drug resistant organism, or you've got diabetic foot ulcer where osteomyelitis is a risk, it is strongly recommended that you liaise with your medical microbiologist in terms of how to obtain the best specimen from the wound. The laboratory is alerted, and then they can advise you on antimicrobial therapy. Currently, the laboratories promote a swabbing technique known as the Vivien technique. Of all the techniques, this is believed to give the best representative sample. So after you have debrided and thoroughly cleansed the tissue, you press a sterile swab over a centimeter square area of the wound with sufficient pressure to express fluid from the wound bed. please avoid the edges of the wound at all cost and avoid areas of slough. You should only ever swab the debrided areas. If you lack exudate in the wound, it's a good idea to pre-moisten your swab with sterile water or sterile saline. And then finally, you must get the specimen to the laboratory in under 3 hours. At this point, I'm going to be handing over to Liezl, because now we're getting into the nitty-gritty, and this image says it all. Slough, of course, is an immense physical barrier to wound healing. So over to you, Liezl.
Thank you so much, Helen, for that introduction as well, and where we are within this presentation. It's such a pleasure to be with everyone here today. What is so important is we need to think about this is, why do we debride? What are the reasons for us to use things like the Cutimed debrided pad, to use all the different methods that we're going to use? The key terms that we need to look at is what Helen's just spoken about. When we look at wound biofilm, which is a complex community of different species of bacteria, remember that they form maturity within 48 to 72 hours. The key terminology that you need to look at is that what we are facing with what we face on a daily basis, which is our hard to heal wounds. These are wounds that often fail to respond to the normal base care. And we need to think a little bit out of the box. And part of this is that we follow the key principles as per the new consensus document that was just published. In this consensus document, there are 4 methods that we need to look at in wound cleansing. And please remember, the whole reason why we do debridement is to convert a chronic or stalled wound into an acute wound by removing the non-viable tissue, which stimulates inflammation and microbial growth. It's so important that we kickstart the wound back into the proliferation phase. And we need to get rid of senescent cells because they are not at all helping us to get that wound to heal. So in this consensus document, there are 4 points that we need to focus on. The first one is that we need to clean the wound and the peri-wound skin. It's not only about the wound bed, it's also the surrounding skin. So you need to remove the vitalized tissue, the debris and the biofilm, but you also need to clean the surrounding skin by removing dead skin scales, colors, hyperkeratosis in order to decontaminate it. You will see from the photographs on the skin, washing a patient's leg is still very good to assist with wound healing. The second thing that we need to do after cleaning the legs and the surrounding skin or wherever the wound is you need to debride. You need to remove the necrotic tissue, slough, debris, and biofilm at every dressing change. Because remember that biofilm develops within 48 to 72 hours. You cannot only debride the wound bed itself, you also need to refashion the wound edges. So you need to remove the necrotic, crusty, and or overhanging wound edges that may be harboring the biofilm. You also need to ensure that the skin edges align with the wound bed so that you can facilitate that epithelialization and that epithelial advancement. This is all part of wound contraction. And as you can see on the screen, there are various methods where you can use this. And this is where our surgeons and our podiatrists also play a big role in chronic wounds. Fourth in this whole cascade is that you need to dress the wound. You need to address the residual biofilm while preventing or delaying regrowth of the biofilm by also using dressings containing anti-biofilm or antimicrobial agents. All of this forms part of the whole actions that we use to clean wounds. It's not just one step, it's a 4-step program. And part of this program is that we go back to basics and we look at the wound bed preparation paradigm. We are all familiar with the wound bed preparation paradigm. The Wound Healing Association of Southern Africa also are very consistent in their consensus documents in using this as the basis. And this is where we need to look at whether a wound is healable, where it can be healed with adequate blood supply or the underlying cause can be addressed, or whether it's a maintenance wound on a non-healable wound. You are only going to debride healable wounds with active debridement. With non-healable wounds, you need to be very conservative in your debridement. And we're going to talk a little bit further with regards to when, how, and why to debride when Tshidi takes over from me in the next section. So without further ado, I would like to introduce our next speaker, which is Tshidi, talking from her perspective as a podiatrist on how do we debride.
Thank you very much, Liezl. As Liezl has said, she has made us aware that Debridement is an optimization of the pathophysiological abnormalities of a wound. This is an opportunity to move a wound from one stage, which is a necrotic stage, to an acute stage. How do we debride? Whichever implementation or type of debridement we choose has to speak to the benefit and the risks. It also has to speak to the need for it. Is there a need for us to debride at that point in time, or do we need to move on? Why do we debride looks at reducing the pressure on the wound due to the calluses that are forming, the necrotic and devitalized tissue that is actually hindering and delaying healing. We also need to look at refashioning the wound and exposing the dimensions of the wound. And Dr. Jandera will talk about infection and other things as we go along. But more so, as Helen has also educated us, bioburden is one of the things that is a problem in wound healing, and debridement can assist and facilitate in removing it and also encouraging wound healing. When we're looking at the types and methods of debridement, we could be spoiled for choice. However, we should be making decisions that are knowledgeable and that are more informed. We're looking at the types of methods that are available to us, and according to the consensus document, sharp debridement is the gold standard. And it is a gold standard due to the fact that it obviously looks at actively removing the bioburden. But also this should be done within the boundaries of the scope of practice. And I need to also try and emphasize that. We're looking at lava therapy, which is your biologic type of debridement. It is easier to use these as opposed to probably then using sharp debridement. We have debris pad. The debris pad also, it's used as a mechanical debridement mechanism. This is also quite effective in terms of removing 99% of bioburden. We also look at your surgical type, and this is where we need to be an interdisciplinary team where we involve our surgeons as well in terms of assisting in the more aggressive approach of debridement. Next slide, please. When should we debride? We need to look at the when and the how and the why. So the when is similar to the why. All healable wounds need to be debrided. We are looking at reducing bioburden. And in order for us to do that, considering that biofilms, they obviously return in the space of 48 hours, we need to continue doing debridement regularly. Also looking at, we need to know whether the vascular status is determined. It won't benefit the patient if we debride an area that is not vascular, doesn't have proper vascular supply. We remove infected tissue and slough, and we also disrupt biofilm in the process of debridement. Now, in summary, we're looking at slough as a hindrance to wound healing. It prevents normal wound healing. It also mimics infection. Therefore, our diagnosis will not be accurate because we are assuming or we are making decisions based on what is on top and not necessarily looking at the whole wound that is exposed. Slough also attracts the microorganisms. Therefore, by not removing or debriding it, we are then allowing an environment for growth of infection. It also poses a risk for infection. If we leave the slough and we do not debride it, what we are finding is it will obviously put the patient at risk of developing infections. Let us continue debriding within our scope of practice, choosing the correct method and modalities that will assist us. And these methods can also be used together as adjuncts, and we can combine any other so that we are able to get the desired results that we want. I will now then give to my colleague, Dr. Jandera, to discuss further when not to debride.
Right. Okay. Do we have the next slide? I think one just has to make sure that what you're dealing with is actually a wound, and be careful that you don't debride something that has a different pathology. So for instance, you're not going to be able to debride and heal a carcinoma. And there's some very good examples of quite a fungating breast cancer on the right and a head and neck cancer in the second picture. If you haven't staged your pressure injury, it's also not advisable to debride. And then obviously gangrene would require surgical treatment. Other examples would be pyoderma gangrenosum. Very important to look for melanoma, especially melanoma on the sole of the foot, which is quite endemic in areas of the country, which presents with what looks like an ulcer, but is actually an acral lentiginous melanoma. But most fungating cancers are fairly obvious, as would be radiotherapy burns. We're now going to move on to some case discussions. And being a surgeon, I'm going to give you a slightly different slant on some of the treatments. So if we go on to the first case, this is a lady, an older lady, who's got a background of hypertension. Can we go?
Put you in here, Helen.
Okay, great. Who's got a background of hypertension, varicose veins. She's had a 7-year history of leg ulcers. She's had 10 years previously had bilateral forefoot amputations. And this particular ulcer was precipitated by a traumatic incident, which was mismanaged in a smaller hospital. So she then presented to a wound healing service, to Liezl actually, and she had a persistent polymicrobial wound environment with resistant bacteria. And sometimes something like DebriClean or a more conservative approach, just you see that you're getting nowhere. And in a small proportion of wounds, it doesn't help to do the same thing over and over again if you aren't having any progress. And at that point, it's perhaps a good idea to consider that you might just need a friendly surgeon. So working together with Liezl, we took this patient to theatre. We actually managed like a really state-of-the-art wound treatment for her. We took her to theatre and we debrided. And if you can see, that's my surgical debridement in the center upper slide. And you'll see that in essence, I've actually done a sharp debridement of the entire area. And in a way, I've almost excised the wound completely. I've even cut up into the normal tissue to see that, that it's all clear, because sometimes that slough extends underneath the surface of the skin. We then treated her with negative wound pressure therapy and intravenous antibiotics for 7 days, and then took her and grafted her, and her wound remains closed, I think, nearly a year later, Liezl, after struggling a lot. So just remember, surgeons are around and we are around to help. Moving on to the next case, this has happened some years ago. And if you look at the slough at the bottom of the wound, I think you'd see that perhaps if we'd got to this wound a bit earlier and we'd been able to use the mechanical debridement, because you can use it in that area, something like DebriClean would have been wonderful, but it didn't exist at that time. And this is a patient with a mixed leg ulcer, and eventually also required going to theatre, having a thorough debridement, and then was grafted, and the graft remained closed. If you have an infected environment without good granulation tissue, there's no ways your skin graft is going to take. So in conclusion,
Vivien, I'm gonna come back to you just now, because I would like Tshidi just also to talk about her case studies, and that we end off with the difference between the acute and chronic. So if I can just quickly go in reverse, you said there's always a little bit of gremlins around. So Dr. Jandera just spoke about the venous leg ulcers, and this is a case just to illustrate to you, when you use the Cutimed DebriClean debridement pad, same day before and after, this is the results that you can get by using this product. So it really assists you in debriding that stubborn fibrin that's on the wound. As you could have seen from the video clip, the debridement pad has 2 parts to the debridement pad. The one is what we would say a more coarser or rougher, in my Afrikaans accent, area, and the other side is more smooth. So if you've got a patient that's squeamish or the wound is painful, rather use the smooth side to do this. In a patient like this one that you see on the screen, we would opt for the more coarse side to actually lift that fibrin. Here is an example of a diabetic foot ulcer where we used the DebriClean pad also before and after same day. You can see there's a layer of fibrin on this wound. There's some open tendons. So we are very careful in using the coarse side for the surrounding area, removing the senescent cells, but using the smooth side more onto top of the tendons to make sure that you don't damage those tendons. Tshidi, this is one of your cases, if you would like to comment on that for us.
This patient is the 67-year-old male patient who developed a diabetic blister, and it obviously then escalated into an ulcer. If you were to look at the picture on the left, the wound has got fibrin on top. It has little pimples, and as we debride it, you can see the friable wound bed as well. Most of the slough has been removed. One of the things that we realized while we were debriding is that there was less pain felt. So this actually worked well for us in terms of debriding a wound without having pain on it. Next slide. This lady has bilateral pressure injuries or pressure ulcers. And if you were to look on the left, we did sharp debridement on the edges because of the callus or the hyperkeratosis. And we also did the same for the contralateral leg or foot. And a week later, when she came for re-debridement and redressing, those were the results. The wound had reduced in size, and the wound bed was much cleaner, as well as with the offloading, it assisted as well in taking off the pressure from the wound itself. This is a 36-year-old female. She's got sickle cell anemia and has had this wound for more than 3 years. And when we saw her, the wound had serous fluid, it also had slough, and it has patches of redness on it. These wounds are generally painful, and on debridement, there was pain, but it was not as much. However, if you were to look at her wound a week later, the size of the wound has reduced, the edges have now epithelial tissue, and she was on the road to healing, and the wound had improved in terms of what it looked like. This is a classical case that we see during winter. There's a 66-year-old female patient who used a hot water bottle and has burn wounds. Because of the area where the wound is, we have to be cautious of doing sharp debridement due to how bone is close to skin. And using the DebriClean pad has actually assisted us in assisting the wound and removing the slough and assisting the wound in terms of healing.
So when we look at this picture here, this is a traumatic injury, abrasion injury. And types of injuries like this, the DebriClean pads really work well to remove debris in traumatic wounds. Even if there's still some dirt trapped in it, it's easy to remove that. And then you can cover that as well with addressing like the 4 points I've said before. Just on this point, when we use this in traumatic wounds, please remember that there's already a pain component with regards to that. So be gentle when you do that, but make sure that you do remove all the debris that's on the wound bed itself. Dr. Jandera spoke also about the chronic venous leg ulcers before and the mixed leg ulcer. Please remember one thing is that when you see slough on its own, like Helen has mentioned before, does not mean that there's infection. It only means that there's dead tissue. It's necrotic tissue. So you need to clinically look at the signs of infection before you say that this is an infected wound. Slough on its own does not say that it's infected, but it can be an excellent growth medium for infection. Dr. Jandera?
So in conclusion, I think we would all agree that DebriClean is a significant advance in wound management. And it's useful in both chronic wounds, which we're all accustomed to, but we mustn't forget about the acute wounds as well. And it's a welcome addition to the modality of debridement. And I think sometimes even saves the patient from a surgical procedure. This presentation has also emphasized the importance of debridement in wound healing, and then offered us a new smart device to help us to achieve this. Thanks very much.
So You guys can see again here the DebriClean, the way that it's working on wounds, the different sides of the device as well. It's so important when we are going to go through the case discussions now and take your questions and answer sessions, that we will be able to go back to some of the photographs to answer your questions beforehand, after that as well. It's always funny when you do a webinar, you would like to see the audience, you'd like to see who you're talking to, and at the moment, all that I can see is a screen and some of my colleagues on the other side. So I'm so glad I can at least see you guys. I assume that all the rest of the people are still online, and hopefully you're not going to leave us now, but are actually going to take part in an active discussion about what is going on with debridement. You need to remember the 4 principles. You need to clean the wound and the peri-wound skin. You need to debride the wound bed as well as the senescent cells around the wound bed. That's where it's so important in the diabetic foot where the podiatrist is active, that you remove the callus, take off the pressure. You need to refashion the wound edges, specifically also with pressure injuries and pressure ulcers. Remember, if those edges of the pressure ulcer are epibole because it's too dry and there's no growth because it's a cavity with undermining, if those edges look like this, we need to smooth them out so that we can get epithelialization. And this often also requires, or not often, it requires surgical intervention to get this sorted. And then last but not least, we need to dress the wound with the right dressings. So for us to go ahead, we're going to take some of your questions now and see how many of them we can answer during the time that's still available to us. One of the first questions that came up was, Tshidi, specifically for you, with regards to hyperkeratosis. Would you like to just answer this question on what is hyperkeratosis?
Thank you very much for the question, Liezl. Hyperkeratosis is a thickening of the outer layer of the skin and where the protein keratin builds up. Now, we usually use hyperkeratosis and calluses interchangeably because hyperkeratosis is increased keratin buildup that results in callus formation. However, callus formation is found in areas of increased pressure. Those are that's one of the differences that we are seeing. So calluses, you'll find it on the bottom of our feet where there's increased pressure, and then hyperkeratosis would be anywhere in the skin where there's increased buildup of that keratin.
Okay. Another question that came in was the use of the debridement pad. Was this painful for the patient when you use it on these type of wounds? And what about hypersensitive wound beds? Like I answered previously, depends on how you use this. It's sometimes for patients more painful where you use a scalpel to do this debridement. With a DebriClean debridement pad, you can actually showcase yourself how much pressure you're going to apply to actually get rid of the fibrin. And remember, there's 2 parts to this debridement pad. You can use both of them. We would also suggest that if you have got a lot of senescent cells, that you can use the coarser side to get rid of all those hyperkeratosis like Tshidi has just mentioned. The next question that came up was,
sorry,
Liezl, for you. Yes.
Liezl, if I may just interject here, yes, while we're talking about pain as well during debridement using a pad. Again, as Liezl's pointed out, you've got the rough and the gentle aspects of the pad. Once you saturate the pad, it makes it quite soft and malleable, and it conforms to the shape of the wound. And we would suggest that you use little circular motions, gradually increasing pressure and gauging the patient's response. The other thing to note is that if the patient is experiencing pain, there could be one of 2 most common things. The first is infection, subclinical infection, because as I mentioned in the biofilm, the bacteria are producing proteases and exotoxins, and these irritate the tissue and cause pain, and obviously contribute to this low-grade inflammation. And the other caution that I want to mention is that if your patient is experiencing a lot of pain and this wound is not progressing, particularly if the wound bed is quite exuberant, just look out for your patients that might have an autoimmune condition, and they could have an underlying vasculitis, in which case they may need to be referred back to the rheumatologist or for a vascular assessment. But otherwise, something like paracetamol is usually more than adequate. Would you agree, Liezl? you know, taken half an hour before the procedure if the patient is finding it painful, because we don't want the patient to anticipate pain, because we know that this also results in hypersecretion of hydrocortisol, and this also can get in the way of healing.
From my
Would you agree, Liezl?
with the DebriClean pad, even with patients that's got really painful ulcers, they were able to tolerate this. Just make sure that the pad is really moistened, because if it's a dry pad that you use without adding moisture, that's when it starts to get painful. That you can soften it up a bit and you use the moisture as your vehicle, it works much better and there's less pain. There was a question coming through that I would just like to put to the group as well. Stephen,
about cleansing the peri-wound
numb before using the DebriClean. And I think, Helen, you've already answered that question in a sense. You can give the patient paracetamol, but in general, when you use this, there's no need to go and use anesthesia beforehand.
No, and interestingly, you know, when the four of us actually discussed our cases that we've used the DebriClean pad on, what is that actually really positive is when the patients see the before and after effects, then they actually realize the benefit of this. And, you know, there may be some initial discomfort, which I think is part of apprehension as well. And once the patient actually understands what's going on, as Liezl said, pain wasn't really an issue.
Next question was, how many wipes can you get out of one pad and how many times do you wipe? It's almost like how are you going to clean the baby's bum? One wipe or two wipes. Tshidi, how
you see, it's dependent on how the patient is firstly responding, because once the patient starts feeling pain, then it means you have to stop. In terms of the wipes, we know that the DebriClean, for a patient to get proper results and for us to be sure that there's good debridement, you have to debride with the DebriClean at least 4 times. However, based on the cases that we've seen, we've done one wipe, circular motion, as Helen had educated us as well, and that has shown results immediately. So in my case, that's how I used it.
And I'd also like to, those of you that are watching, if you cast your mind back to the video, the debridement pad is made of these little looped filaments, polyester filaments, and the loops greatly increase the surface area of the pad. So in actual fact, one can actually do multiple circular motions with increasing pressure, and the pad will accumulate. It can take quite a lot of debris. Again, with regard to the hyperkeratosis, and depending on the nature of your wound bed and the etiology of the wound, you would want to maybe conserve the coarse section of the pad for the peri-wound skin to deal with the hyperkeratosis, and then only use the gentle part of the pad on the wound bed itself, because one doesn't want to cause cross-infection or cross-contamination from the peri-wound skin into the wound bed.
From my experience as well, when we've used the pad, is we will wash the leg first with whatever you want to wash, with soap and water. Since I'm focused on leg ulcers, this is what we do in our center. But what we've seen in preparation, say for instance, you would like to prepare a patient for a skin graft, and this is where Dr. Jandera and I also work together, is this modality makes it easier for us to prepare the wound bed while we're waiting for authorization or whatever is going on, that you keep that wound bed cleaned so that you can do whatever procedure you would like to do if you want to do a skin graft after. And I think the DebriClean can be very valuable in that sense, in preparing wounds, like to do a skin graft and secondary closure later on, in preparing that wound bed, because what I've seen in practice, the longer you have to wait before you can do a skin graft, the higher the risk of having contaminants, the higher the risk of getting infections, and also the resistant bacteria. So if you do regular debridement with something like this, this can get you a better result when you take the patient to theatre. What would you comment on that, Dr. Jandera?
I think what we have to remember that the medical aids, unfortunately, are really quite difficult. And I know for the first patient that I presented to you, it was a mission to get them to agree to 2 trips to theatre, 1 to debride, to make sure the wound bed was fine and to graft 7 days later. So if we can get that wound debrided, clear of slough, and ready for a skin graft in an outpatient setting in a wound clinic, much easier to get authorization with a medical aid. And obviously, patient only has 1 anesthetic and not 2, which is safer for them.
And I'd also like to add, as an infection preventionist, the gold standard, and it's considered good practice. There was a question, what should you use to cleanse the peri-wound skin? So this is both in the pre-operative setting as well as in the wound clinic. One should be using chlorhexidine gluconate. So you would use the very same chlorhexidine gluconate liquid soap that one uses for aseptic hand hygiene. However, you should not be using the same bottle that you're using for your hand hygiene. You should have a separate bottle that you're decanting into your basins in order to wash your patient's leg, and then use a disposable cloth, something like a daily cloth, to wash the peri-wound skin. And with chlorhexidine, it's very important that once you've worked up a lather on the peri-wound skin, is just to leave the suds in situ for at least a minute, because the chlorhexidine chemically binds to the epidermis, and you don't need to rinse terribly well, and this has a residual effect and carries on killing the bacteria on the peri-wound for several hours after the washing exercise. So if you are in a wound clinic situation or even doing home visits, it's considered good practice to use chlorhexidine on the peri-wound skin.
And one of the questions that came in as well was, should you clean the wound again after the debridement, after you've used the debridement pad? The debridement pad on its own, in my experience, is good enough to clean that wound bed, that you don't need to do a whole cleansing again. How did you experience that, Tshidi?
In my case, you found that, yes, it bound to the slough or the debris that you are removing. But if to ease myself, I would just flush with normal saline and just wipe with sterile gauze just to make sure that it's all clean. Another thing is when you're doing the peri-wound edges, the remnants will obviously stay behind and be left behind. And I find that I want to work in a clean environment, so I would just flush and just dry with sterile gauze, and it worked well. So I would advise you can flush again with saline water and wipe with sterile gauze.
I'd also like to come in at this point and go back to the issue of biofilms that we know are present in chronic wounds that are microscopic and we can't see them. And it's also important to realize that one can never remove biofilm entirely. The whole objective of this exercise is to disrupt it or break it up. So one should be, when you're using a debridement pad, one should also be using a cleansing agent that you know to be biofilm active. And this would be agents like your hypochlorous acid or your betaine or detergent containing wound cleansers. And after you've used the debridement pad, it would be a good idea, ideally, to use a detergent-based cleanser or a hypochlorous acid to get rid of and also to disrupt the biofilm, because it's important to indicate that normal saline has no effect whatsoever on biofilm, because biofilm, you must remember, is an oily, fatty substance. So it'll be like trying to clean your frying pan at home under the running tap. One does need detergent agents in order to disrupt the biofilm. So if you can use an agent like this, but after using the debridement pad, the normal saline would be effective for washing away the debris, certainly.
In our clinic, Helen, what we do is we use a variety of antisepticums. We use your PHMB and betaine surfactant as well, and we use also hypochlorous acid to do that. So it often helps to just spray the area afterwards, if you're concerned about that.
Yes.
There was also a question that came in with regards to the size of the DebriClean. The size works well for large wounds, but I think, Tshidi, you can answer this one. How do you go about this big thing when you clean in between toes?
Like I said before, we look at the risk and benefit. For me, I know the pad might be considered not to be cut, but I cut the pad and it worked just the same. So yes, it's a bit big. So in areas like your digital wounds, it was very hard and I had to cut the strips and I used the strips and they did work.
So from a manufacturer's point of view, you shouldn't cut the debridement pad because it's made that way and it's
exactly.
So it will disintegrate. And so one thing we would like to ask is make a little bit of smaller pads so that we can with that. So from a panel perspective, that would be nice. And I think from the audience as well. But we don't recommend to cut the
yes.
It's not the best practice because you are going to not have the functionality which it's made of within the different layers. Another question that came in is how easily is chlorhexidine gluconate liquid soap contaminated in its container?
Oh, very, very easily, Liezl. The moment you take the lid off any antiseptic, you know, you've got the, what would you call it, you know, for the screw cap. When you pour your liquid or you decant out of the bottle, you can't help but getting liquid running down those threads where the cap goes. And that's literally becomes a highway for the microbes. So as a general principle, it's better to have smaller containers. This is not always easier in terms of a cost-effective benefit, but chlorhexidine gluconate liquid soap, if you've got a busy clinic or you've got a practice, one would get through a bottle fairly quickly. I'm very pleased this question was asked because the other thing that I also want to mention here as an infection preventionist, please be very aware of decanting antiseptics like chlorhexidine into smaller plastic bottles. Chlorhexidine reacts chemically with certain plastics. It binds with them. So it looks like chlorhexidine. It's still the same pink color. But in actual fact, your 4% concentration may be under 1% if you're decanting into another plastic bottle. So it's very tempting to go to the plastic shop if you're a practitioner or if you've got a clinic and buying smaller, say 100 ml bottles and then decanting into these plastic bottles. Unbeknown to you, your chlorhexidine gluconate has bonded with the plastic of these bottles. So generally speaking, your harder, more, not your soft plastics, your harder, more durable plastics are safer for decanting chlorhexidine. And the other thing is you must always protect all your antiseptics from light and heat. So for the P&Ps, for example, that are listening in this evening, please, I urge you to carry your antiseptics in a cooler box in the back of your car, because not only will it be a dark space, but it will regulate the temperature. Because if you look at the material safety data sheet of your antiseptics, you will see that antiseptics become unstable from 22 degrees upwards. And if you think about the hot car, most of your antiseptics are becoming denatured. So I hope that answers that question. But yes, they become rapidly contaminated. So you do need to decant very aseptically.
Thank you so much for that, Helen. Another question that the panel can maybe answer as well is, what can I use to loosen the slough before I use the DebriClean? Now, Helen also touched on several of the solutions and antisepticums that we can use, but in general, if you've got stubborn slough, you can use your gels like your PHMB antisepticums to soak the wound beforehand before you apply any of your DebriClean debridement pads. Also remember, when you use moisture in the debridement pad, that will help you already. The wetter the pad is, the better you can loosen the slough. That's the whole idea behind using something like the DebriClean. You will be amazed at the action and how much slough it can remove just by using it in the correct way, like the video has explained to us in the beginning of this presentation. Moisture is key in removing slough. If it's very stubborn, it's very thick slough, and you are really struggling with that, perhaps it's time that you do get your multidisciplinary team involved. And maybe those are cases where you need to consider surgical debridement if there's really trouble with this patient and it's a stage 3 to 4 pressure ulcer.
And depending on the frequency of the dressing changes or when you'll next see the patient, and of course any underlying comorbidities and a tendency, to infection, once you've debrided and cleansed the wound, you're then going to need to select a dressing that is autolytic in nature, that's going to carry on debriding and softening the slough until the next visit. And obviously alginates and gels are highly effective at this, which will then again prepare your wound and make it even more conducive to the next DebriClean when you change the dressing.
I'm going to play a bit of devil's advocate here with this question that's coming up next in saying, can we reuse the DebriClean? Is it only for once off, or can I wash it and re-sterilize it and reuse it again?
Once off.
I think the panel's reactions is sort of answering that before we say anything like that.
Just remember your Staph aureus, your E. coli, and your fecals. Will you reuse your toilet paper? No, I don't think so.
No, I think I agree on that. Tshidi, do you agree on that one? Once off.
Once off, and you should be okay.
Dr. Jandera?
I got scared.
Agree, once off.
Once off.
Okay, so I think that answered that question. Please, it's made to only be used as a once off debridement pad, and that's the reason why we would not advocate to cut the debridement pad, because then you're going to leave it, put it back in the cupboard and reuse it, and if you're not going to remember for who you've used it, this is where you're going to get into trouble as well. So
it's sterile. Yes, it's a sterile.
Necessity to make smaller ones for us to use in between the toes and fingers, but we would like to keep the environment sterile and have a clean area to work on. There was also a question to ask, please elaborate on what you mean about with soaking the wound. And that's probably with my comment when you use something like the PHMB betaine combination, or you use a hypochlorous acid, saline, anything, any solution that you want to soak the wound. It's a simple thing that you can do. You take gauze, you moisten the gauze, put that onto the wound bed. What we do in our practice is we cover it with cling wrap, because then you keep the moisture contained. Cling wrap is bacteriostatic, so you are not going to contaminate the wound. But the other thing that cling wrap as well does for you is it keeps the wound temperature the same. So you get that temperature immediately back to normal, and you can soak a wound for anything, depending on what you want to achieve, for 10 minutes, 20 minutes. So in general, we would soak a wound where there's a high amount of infection. There's really, it's a, for lack of wording, there's my Afrikaans coming in again. There's a erg geïnfecteerde wond. Okay, so it's really Helen, help me here. I've lost my.
If you've got a lot of debris, you've got that shiny fibrin layer, and obviously the best thing would be your PHM, your polyhexanide and detergent combination, or your hypochlorous acid, because that's going to start breaking down and disrupting the biofilm in readiness for you to scour it. It's exactly the same principle as washing your dishes. You obviously you would soak them in the sink, and they make them that much easier to wash, don't they? And that's why you want to use something like hypochlorous acid or a detergent-based cleanser like PHMB. I can't remember what I was going to say here, but I also just want to say at this point, Liezl's talked about using sterile gauze, and you soak that on and put the cling wrap. That works beautifully. Please do not soak your limbs and your feet in basins or buckets.
No.
That is out now. Very, very bad news for cross-infection. And the other thing, it causes maceration of the wounds, and it will predispose them to even more breakdown and infection. So please do not soak wounds in buckets or basins.
Yeah, and what I forgot to say, and what my Afrikaans came in, it's a grossly infected wound. Those are the ones that you wash and you clean and you soak to make sure that you remove the contaminants and you penetrate the biofilm as well with that. So that works always. I just want to check for the next question.
Oh, I think we've got a question here about contraindication. Mary Jane Mtamti has asked about where is contraindicated to use the debridement pad. Maybe we could go back to those slides, Liezl.
Unfortunately, I'm not able to share the screen at the moment.
Oh, okay.
And so those are the slides that, if the audience will remember, where Dr. Jandera spoke on where it was the pyoderma gangrenosum, the unstageable pressure injury, those slides of the pictures there, and the cancers, the fungating cancer, as well as the, there were a few others as well on the screen. So you can, if you can answer that, Helen.
I'll start off with the fungating wounds. If you can cast your mind back, and that would also go for your melanoma on the sole of the foot. Remember that a fungating wound is tumor. It's actually not a wound. And tumors, by their very nature, are highly vascular. So when one is dealing with them, you're dealing with a high exudate levels. You're dealing obviously with terrible odor, and you're dealing with all this necrotic tissue. And they are very, very heavily colonized with fecal bacteria. That's where the smell comes from. So to actively debride fungating tumors is strongly contraindicated, because you will induce bleeding, certainly, especially in your head and neck tumors. In fact, when one is doing wound care for fungating wounds, you should always make sure that you have alginate dressings closely at hand, because they contain calcium, and this is a useful hemostatic agent. Alternatively, some adrenaline, 1 in 100, is useful. Even hydrogen peroxide is a useful hemostat if you're in a low resource setting. But above all, do not use sharp debridement or a debridement pad on a fungating wound. I'll just talk briefly about your unstageable pressure ulcers. Oh, thanks, Liezl. There's on the left-hand side, you can see your fungating breast wound there. You can see your head and neck carcinoma. These wounds, these fungating tumors, they invade large blood vessels. And in the case of your head and neck cancers, gosh, in all my years in oncology, it's actually really very sad, because these patients, they're very sadly, when they die, it's normally as a result of massive hemorrhage. And in this gentleman here, in the second image from the left, this carcinoma will invade the carotid, the internal or the external carotid artery, and these patients invariably hemorrhage to death. So that is why debridement is contraindicated. In the heel there, where you can see your unstageable dry necrotic tissue there, these are what you call maintenance wounds, and one should not undertake any sort of active management with these wounds. The clinical management is to elevate, protect, and keep this necrotic eschar dry. That is your clinical objective. Healing is not the objective for these kind of wounds. You just elevate and protect and just keep inspecting. Vivien, do you want to come in on the gangrene on that last image?
Well, gangrene is a surgical condition that requires usually some form of amputation, because it means that there's no more blood supply to that area and there's no hope of that tissue from recovering. If you leave that patient, the gangrene will progress, get worse. The patient can develop septicemia. So it's really not something to just keep dressing. It's something that requires relatively urgent surgical intervention.
Another question that was there for you, Dr. Jandera, specifically is, are there wounds that cannot be skin grafted, where skin grafting is not an option at all?
Yes, definitely. So skin graft requires, because of the nature of how a skin graft heals. So a skin graft is a thin area of skin which is placed onto what would be a bed, okay? And the bed must have enough vascular supply for that vascular supply from the bed to grow up into the skin. And we call that the initial process called inosculation, where it then forms its own, it actually provides a blood supply to the skin, which then allows it to live. So if there isn't enough blood supply to the area that the skin graft is put on, and examples I can think of are bone without periosteum, tendon without peritoneum, then you are not going to have, you need a good bed for a skin graft to survive. If you have a defect that needs to be closed and there isn't a sufficient bed, and you needed to close a defect of some size, you would consider doing a flap. So a flap is moving an area of tissue that has its own blood supply and swinging it into the area of the defect. And there are various ways of doing that. And then
Okay, thank you for, I think that's very important when we look at that. The next question that we got was from Petra Cole. Hi, Petra. If a patient has several wounds, should separate DebriClean pads be used for each wound? For example, 7 wounds on one lower leg. In my experience, that's not necessary at all, because you are going to clean the peri-wound skin, you are going to clean that whole area. Unless your pad is completely soiled because of the nature of the wounds and it's so dirty that you cannot carry on with the pad to clean, I would suggest you use another one. But in general, in all the cases that I've done thus far, I used one, irrespective of how many wounds were on the leg. I see Helen nodded as well, and Tshidi, you've had the same experience with that as well.
And unless if then you're treating 2 separate legs, then you're gonna have to use different, But if it's on the same, and it makes financial sense as well.
In this case, that is when the cleansing of the limb with your chlorhexidine gluconate becomes very important as preparation for your procedure, because you'll decontaminate and lower the bioburden on the peri-wound skin. And all of these wounds will be colonized with the same microorganisms. So even though they are separate wounds, they all belong to the same patient's what we call microbiome. So they will all have identical organisms in them, the different wounds. It might interest people to know is that if you've got a diabetic foot ulcer on the big toe and the patient has a boil on their scalp caused by Staphylococcus aureus, the boil on the scalp that is full of Staph aureus, that Staph aureus will also be in the diabetic foot ulcer in the big toe. In fact, the patient's whole skin will be very heavily colonized with the Staph aureus from that boil on the scalp.
Thank you so much for that, Helen. There's another question for you specifically, Helen. Can hydrogen peroxide be used to soften slough and loosen biofilm before using the DebriClean pad?
This is a great question. In short, no. We should not be using agents like hydrogen peroxide routinely because they are cytotoxic. There is a place for hydrogen peroxide, and here I mentioned using it as a hemostat or to stop capillary bleeding. And here one would use a half-strength hydrogen peroxide merely as a hemostat. This is because when hydrogen peroxide comes into contact with body fluids such as blood and serum and exudate, you have an oxidation reduction effect, and that's why it bubbles. And this little oxygenation bubbling effect seals off your capillary bleeding. That is really the only instant where I would use it. Similarly, again, Vivien might like to comment here. If one is incising and draining an abscess that is full of pus and Staph aureus, certainly half-strength hydrogen peroxide is useful as a mechanical cleanser initially to liberate and remove the pus. But one should not be using hydrogen peroxide routinely in wound management. As we mentioned before, you want to moisten your DebriClean pad with something like sterile normal saline or a detergent-based polyhexanide cleanser or hypochlorous acid. Don't use hydrogen peroxide to soften slough or cleanse a wound, because it will be cytotoxic and it will further impede the healing response.
I think it's an extremely toxic product. It's also very painful. If I think about how I saw it used in my training, we used hydrogen peroxide when we you get these patients that come from St. Elsewhere, from in a very rural area, and they've got maggots coming out of their necrotizing fasciitis. That's the kind of patient you use hydrogen peroxide on. And yes, we have used it on abscesses as well, but even that we don't tend to use that commonly. I can just think of the really drastic things I saw as a trainee and saw my seniors using hydrogen peroxide, and yeah, quite happy to see those maggots bubbling away.
I can say, I can vouch for that as well. One thing where I see hydrogen peroxide works very well is if you've got this spontaneous maggot infestation and you really want to get rid of the little buggers, and it works well to get rid of them. But please remember, this is not something that you need to use routinely to clean your wounds with.
And when you use your hydrogen peroxide, you must follow it up with normal saline to rinse it out.
That's right. There's another question that I think is a very important question to touch on when we talk about maintenance wounds and also palliative care wounds. The question was, are there wounds that will never close, like maintenance wounds, or if it doesn't close, what are the options? And it's so important here that I think we go back to the wound preparation paradigm. If you need to go and look again at, is there enough blood flow? Dr. Jandera mentioned it earlier. Nothing will work if there's not enough blood flow. That whole question about VIP, vascular infection pressure. Is there enough blood flow? Did you treat the infection? Is there still ongoing pressure on the wound? If this diabetic patient is still walking on the diabetic ulcer, there's no way that that's going to heal unless you do something by changing their orthotics, changing their gait pattern. Ulcer is not going to heal unless you remove the pressure. The venous leg ulcer will not heal unless you treat the underlying venous hypertension and you work with that. The arterial ulcer will not heal if you cannot restore the blood flow. And those are the main keys with that. So if it's a maintenance wound, you need to understand, why is that wound a maintenance wound? Is it the patient's socioeconomics that they cannot afford they cannot go to the vascular surgeon, they cannot have the surgery done, or it's purely because there's a lack of support for that wound to go forward. If it's palliative, you cannot expect a wound that's a cancer like the ones that you saw on the screen earlier, the basal cell carcinomas. Basal cell carcinomas you can surgically remove, but if it's a fungal breast cancer like the ones that you've seen on the screen, those wounds are palliative wounds, and you need to do the best you can for the patient.
Could I mention here, Liezl, could I interject? So when you're talking about maintenance wounds, your treatment plan and your treatment objectives will change. Probably the top two, or maybe the top three that you've got to have in your treatment plan is, first, manage exudate. You must use a thirsty enough dressing to manage exudate. In my experience, if you manage exudate adequately, you will prevent the party going on in the biofilm and the slough, because microbes will love this moist, warm environment. If you manage that, you're making it less hospitable for these bacteria. Similarly, your second part of your treatment plan obviously must be to manage and minimize the non-viable tissue. So in maintenance wounds, it's not usually possible to remove slough entirely. But again, with the use of a debridement pad, you keep it at bay, you keep minimizing it, because if you minimize the amount of non-viable tissue, you will then minimize the numbers of bacteria that are living in the non-viable tissue. And then lastly, your wound maintenance must include antimicrobial dressings. And perhaps we could just spend a couple of minutes here, because we are in World Antibiotic Resistance Awareness Month, and we know that our chronic and maintenance wounds are frequently colonized with multi-drug resistant organisms because of the slough and the biofilm. So when one is selecting antimicrobial products, we talk roughly about a 2-week rule. And as an infection preventionist, and my colleagues might disagree with me, but we need to be very careful about conserving silver-based products or silver-based dressings for high-risk cases. And we need to ring the changes and try and only use silver for overwhelming infection to bring the bioburden down, and then rather use your DAC technology like Sorbact or your other antimicrobial antiseptic products in favor of silver, because we're starting to see silver resistance is widespread now across the world, particularly with E. coli and Klebsiella, which is a particularly serious development. Liezl, I don't know what you think.
Well, for me on that topic, and I think it's something that we can talk on for hours, which would be great. But I think for the purpose of why we are here, I would like to, I would comment on that, and I would like to get back to some of the questions as well on that. The important thing whenever you use an antimicrobial is that you need to remove the biofilm beforehand. The reason why we see resistance to silver is because we don't clean the wounds properly and we don't follow those 4 principles that we've talked about in the consensus document, which is unfair to a lot of the antimicrobial products out there. If you are going to use a good cleansing regime where you clean the surrounding, where you debride the wound and you clean the wound bed with something like the DebriClean, that's when you get results of all your antimicrobials. So I would really like to stress that it's not about just slapping on the best silver or whichever antimicrobial you would like. It's about cleaning the wound bed beforehand and then putting it on. That's where products like the DebriClean really makes a big difference. On that note, I want to apologize to Dr. Petra Cole, because yes, I agree with her that maggots are smart little blind handless surgeons doing a magnificent debridement job. You are absolutely right, Dr. Petra Cole. They are magnificent, and luckily you can kill them after 3 days. No comment on that, Vivien. We do love surgeons, but sometimes we wonder. Maggots are definitely doing a good job, but we don't have them there all the time in the wound. And hydrogen peroxide really works well to froth them out easily. There was a question about, can the DebriClean also be used for hypergranulating wounds?
Can I step in?
Yes, please, Tshidi.
Now, hypergranulation, obviously it's overgrowth of granulation tissue. The minute you start debriding granulation, you are bound to have bleeding. Deal with the hypergran first, then once you've dealt with the hypergranulation, if there's any remnants of slough or debris, then you can clean it. However, it's a process. You have to handle and deal with the hypergranulation first, otherwise you're bound to have friable tissue and bleeding.
Yes, I would agree there. And there your hypertonic salines and compression work the best.
There was a comment specifically earlier about compression. When we talk about using a compressed saline gauze when you want to soak the wound. So it's that whole terminology about, are you soaking it, having the gauze that you put on the wound beforehand to soften the slough, or to treat the grossly infected wound to get products like your PHMB solutions to get their full contact time like 10 to 15 minutes. If you have a gauze that's completely so wet that nothing happens, you can cause maybe maceration. In my own experience, I really would squeeze, if you can say, compress out all the fluid from the gauze. It's never that high amount that you can damage the surrounding skin if you soak a wound for 10 to 15 minutes. I don't know how your experience is with that. I feel sometimes if I compress the gauze or squeeze out all the moisture before applying it to soak off whatever there is, the debris, or to get the slough softened, you don't have enough to get the process started. So I would not, from a personal point of view, not recommend that you compress the gauze and get rid of most of the fluid before you apply that to soak. Your viewpoints on that, team?
You need the fluid to do its job. The minute you remove the fluid, you've removed the reason why it should be there. So you need not to squeeze it out or compress it. Use it as is.
Any other comments on that? Helen, you're happy with that one?
Oh, yes, yes. No, it must be moist. And as I say, preferably using an antiseptic or a lotion that we know breaks down the lipid bonds of the biofilm, because the biofilm is a very, very complex structure. We still actually don't understand the true nature and how biofilm is structured, but we do know that it does comprise very, very complex lipid and carbohydrate protein bonds. And to date, only your detergents such as betaine and your hypochlorous acid are known to break these bonds, followed by the debridement pad.
I can certainly agree on that. If we look at throughout the presentation what has come through with this and the case studies that we've presented as a team, and I'm sure we want to actually engage the audience in this. If you're part of this webinar, this is also your opportunity to get your own data, to see how you use the DebriClean pad in your own practices. It's only from experience and using it yourself that you can determine where it's going to be the best in your specific practice. We've had limited exposure to the product since this is the launch, but so far had really good results with the product. It's easy to use. It comes in a good packaging to use. It's easy to moisten that. It slurps up literally all the moisture, and you can apply that on a large surface area with several wounds on the leg or same area of the body part. So overall, it works on tough slough when you use the coarser part of the DebriClean. And you can also use the finer part where there's a pain component or when there's exposed tendons or areas where you're worried about the fragile tissue that's there. So overall, we've seen the use of the DebriClean pad in the use of hard and stubborn and chronic stalled wounds to stimulate that whole inflammatory phase, getting the wound to go into the next phase, into proliferation. But we've also seen that you can use the DebriClean pad in preparation for maybe a skin graft or for surgery. It's also very to use when you've got these hyperkeratose skin or the senescent cells around the wound to make sure that you get rid of the bioload that's containing the wound bed from the sides and from the surrounding skin tissue. So there are various ways that you can use this with. And we would like to challenge the audience that for your pressure ulcers, for your chronic wounds, but not only the chronic wounds, Dr. Jandera mentioned the acute wounds as well, where we would like to clean them up so that we can prevent infection later. If that patient comes in from a motor vehicle accident, why can't we use the DebriClean to clean that patient? It's going to be less harmful, less painful for them, and you can do a gentle cleaning with that. So don't look at the product as only a product to be used on chronic or hard to heal wounds. It can work very well in the acute setting, in a casualty department, in a trauma setting where you would like to get this clean. If I just look at my kids in a sports scenario and next to the hockey field, that really works well for those astro burns just to get that cleaned and get a good environment for that.
Okay, thank you very much for that, Liezl and ladies. So it's been amazing so far, but we realize it is late. So we are now at the end of our official session. For those of you who would like to drop off the webinar, I would like to take a quick moment to thank all of you for attending tonight, and also special thanks to Vivien, Helen, Liezl, and Tshidi for your amazing presentations and extremely valuable insight. For those choosing to leave now, please don't forget to complete your CPD and product quizzes. And don't hesitate to reach out to one of our SCT reps should you have any queries. I just want to mention that the webinar is being recorded and will be available on the microsite till the end of the month. From all of us at SCT, from the bottom of our hearts, we thank you all very much for your contribution. And we wish you all a lovely festive season and look forward to seeing you again in 2021. So thank you. For those wishing to stay on for more Q&A, we will keep the room open and feel free to post extra questions. And then we would close off officially at 8:30 if there is more until then. So yes, thank you very much. So ladies, I'm not seeing any more questions coming through here. So unless there's any other topics from your side that you would like to bring up or raise, I think that we could actually close the event then.
I think we've covered a lot of ground, Jason. I think really that we've talked about everything and beyond. Maggots. So I think we've covered everything.
One comment that I have is that we need to realize that evidence-based care is important. And the reason why we do these case studies and the reason why we go an extra mile to try out these products is because we know that evidence-based care is important. If we can do it, so can you.
Well said, Tshidi. Well said.
Thanks, Tshidi.
Okay.
So, Jason?
Is that it? Okay, well then, thank you very much, everybody. It's been wonderful. I feel like I can debride anything now, but of course I can't. I'm not qualified. So thank you very much for the learning and the education, everybody, and everyone attending. I hope that you stay safe and that you and your families are all safe over the festive season. Thank you very much, everyone. Have a wonderful evening.
Thanks to everyone for your super questions. Yeah.